Welcome to the HCMC instructional video for the use of ultrasound in the diagnosis of abdominal aortic aneurysm. Aneurysmal disease of the abdominal aorta is common and may be found in up to 5% of patients over 50 years of age. It is even more common in males over age 65 with risk factors for peripheral vascular disease such as smoking. About 80% of patients who present with ruptured AAA have no previous diagnosis. When rupture occurs, mortality is very high. Rapid diagnosis and repair have been shown to decrease this mortality. Patients with ruptured AAA can have variable presentations. AAA should be suspected in any patient over age 50 who presents with syncope, hypotension, or pain in the abdomen, back, buttock, or groin region. Ultrasound of the abdominal aorta is rapid, non-invasive, and can be performed at the patient's bedside. The dramatic benefit of ultrasound in the emergency department has been well studied and has a sensitivity of nearly 100%. Ultrasound screening exams for asymptomatic high-risk patients are also appropriate. Elective repair is relatively safe. To perform the exam, a curvilinear abdominal transducer is used. To begin, place the probe just below the xiphoid and obtain a longitudinal view in the standard manner with the marker dot toward the patient's head. Alternatively, a transverse view could be obtained in the same position with the marker dot pointing to the patient's right. Using gentle pressure will help displace more superficial structures. In the longitudinal view, the takeoff of the celiac axis and superior mesenteric artery can often be visualized. In the transverse view, the aorta may be just to the left of midline and is anterior to the vertebral body, which is hyperechoic anteriorly and casts a shadow posteriorly. Measurements should be taken in both the longitudinal and transverse planes from outer wall to outer wall, being careful to keep your probe perpendicular to the patient to ensure a true cross-section. You will also be able to visualize the inferior vena cava, which in the transverse view is just to the right of the aorta, and in the more cephalad position becomes intrahepatic. Distinguishing these two structures is usually straightforward. The aorta will typically have a thicker wall and appear more forcefully pulsatile than the vena cava. The distal vena cava will also be compressible. Once measurements are taken in the proximal portion of the aorta, rotate the probe back 90 degrees and follow the course of the aorta inferiorly. Again, obtain longitudinal and transverse views of the aorta a few centimeters above the umbilicus. Then follow the aorta distally to its bifurcation into the iliac arteries in the transverse plane. The normal aorta typically measures 3 centimeters or less in external diameter, and its greatest extent is typically just inferior to the diaphragm. It tapers to 1 to 1.5 centimeters of external diameter at the level of the bifurcation. An external diameter greater than 3 centimeters indicates the presence of AAA, and diameters greater than 5 centimeters indicate increased risk of rupture. Most lesions are seen as fusiform dilatations, resulting in uniform enlargement of the circumference with an echo-free lumen. Often thrombus is noted in the lesion, usually in the anterior and lateral walls. This view also demonstrates turbulent flow in the lumen of the aorta. This is even more dramatically apparent when color Doppler is applied. This view demonstrates a rupture of the left posterolateral wall of the aorta, which is the most common site of rupture in a AAA. Once detected, attempts should be made to document the location and extent of the AAA in relation to the major vessels. Be sure to include the entire diameter of the aneurysm, which includes both the thrombus and the echo-free lumen in your measurements. The most common mistake in measuring AAA is to include only the echo-free lumen. Bedside ultrasound is an invaluable tool in the screening of patients suspected to have AAA. A scan with no evidence of AAA can be helpful in establishing a second diagnosis, such as renal colic, which can mimic symptoms of AAA. Detecting and documenting the extent and location of an aneurysm can aid in directing the urgency for repair. Aneurysms greater than 4 centimeters should be re-imaged twice yearly in asymptomatic patients. In patients suspected of ruptured AAA, bedside ultrasound can be life-saving. It can be performed as part of the resuscitation, providing diagnosis within minutes and dramatically reducing time to operative repair.